Your life.
Very good evening, all the distinguished delegates and today's eminent faculty, Dr. Ashok Kumar, sir. We are fortunate to have one of the best speaker, Dr. Ashok Kumar, sir. He is a MD/DM cardiology, senior interventional cardiologist at Trela Institute and Medical Center, Chennai. Sir has performed more than 2,000 cardiac catheterization procedures. Sir is a gold medalist for Young Cardiology Investigator Award in 2015, Telangana CSI chapter. Sir has many publications, paper published, and exertions to his credits. So, without wasting much of our time, he is one of the best faculty to have with us today evening, talking about the late breaking clear outcomes trial. And officially welcome all the delegates for this clear talk. Clear talk is a one more facet of Unite Against Dyslipidemia, wherein we are offering a recent development in the field of dyslipidemia management, that is clear outcomes trial, which was presented in 2023 March in ACC, American College of Cardiology. And we have one of the best faculty to speak about clear outcomes trial and clearing all our doubts on bempedoic acid. So I am handing over this session to Dr. Ashok Kumar, sir. Thank you, sir. Over to you.
Thank you, Satish, for the kind introduction. Thank you, participants, for your time in exchanging our views and exchanging our knowledge in this Saturday evening. This is much a relevant topic. This topic on this LDL-CR kind of cholesterol reduction been happening for 3-4 decades now. But it's I don't think it is anywhere near kind of conclusion or near an end. It is ever changing. There is good thing is there is a constant improvement in the management, and this particular vertical, that is dyslipidemic subjects. More importantly, the secondary prevention, where targets are very stringent, and there is enough evidence to say that cardiovascular outcomes are much better with better lipid, especially in particular LDL-C correction, LDL cholesterol correction. So in that aspect, actually in that basket, now we got a new drug, but it's not certainly a drug which can be easily brushed off. It's a drug with a very solid, a strong impact, both in biochemical value reduction as well as more importantly, the recent clear outcomes trial that we got to know that cardiovascular outcome benefit as well with the bempedoic acid. So it's certainly a game changer drug. We can, I personally would wish to view that this is one landmark innovation in the field of cardiology, especially in the field of coronary cardiology or vascular pathology related vascular pathology related cardiology, we can say. So without taking much time, probably I'll take 20 minutes of time brushing through the slides, and we'll be happy to take questions or kind of take your views as well, with the active participation from the participants. So this we know for kind of 2 decades now. The lower is better. There have been longer arguments how lower is better, whether it is less than 70 better, less than 100 better, or less than 50 better, or going less than 50. Does it come at the cost of safety outcomes? Does it come at the cost of something else, kind of adverse impacts? And no, the answer is solidly established. Lesser it is, the better it is. As low as 25. The benefits can certainly, the benefits of cardiovascular adverse event reduction extends till the value goes down to 25. Or who knows, even further lower as well, but at least certainly we know that up till LDL levels 25, with the reduction in LDL levels, there is certainly cardiovascular event reduction benefits. So, but the bigger question is how easily is it possible? But the majority are actually very resistant, or kind of ability to achieve that low levels are very poor with the pathbreaker drug or the first drug in this particular topic, that is statins. So there have been constant innovations along, in addition to statins like 3TP inhibitors, PCSK9 inhibitors, though they're very expensive, not easily available, not available certainly for everyone in Indian developing countries like India. But still, even in spite of combining statins to PCSK9, majority of them we fall short of target reach, or many patients actually in our clinical practice we tend to see, intolerance to statins, so which accounts to close to 30-40%, requiring dose reduction because of inability to tolerate statins. So there's a large gap. There's an unmet need in LDL reduction, be it with efficacy, be it with intolerability with the standard drug or statins. So that's the discussion here. So, but in continuation to the previous slide, with every 1 millimole per liter reduction of LDL, cardiovascular event continues to reduce, and this is even better. The even percentage of event reduction gets better with age. Of course, with age or with advancing age, certainly events are higher. Cardiovascular events are higher because this is age-acquired disease, and certainly, with aging, with the statins or with LDL reduction, the percentage reduction of cardiovascular events are better with LDL reduction. So by all means, LDL has to be reduced. That's the take home. Then is it, uniform with a number of risk factors, or even without risk factor? No, as number of risk factors like say diabetes, metabolic syndrome, impaired fasting glucose, that is diabetes, pre-diabetes, they all exist. The event rates are high, and more importantly, in them the event reduction, percentage of event reduction with LDL reduction is even better. So worse subjects, we need to be even more attentive in reducing LDL. All said and done very well. But management of dyslipidemia is high on priority, and statins are first line therapy, very well known. But do all statin users achieve LDL goals as per guideline recommendations? That's a first concern. And how to achieve LDL-C target after, in spite of maximal tolerated statins? That's a second concern. So second concern was partly started even before bempedoic acid with the PCSK9 inhibitors. But the first concern is, do all they achieve LDL targeted LDL goal reduction? That's a bigger concern. And one more concern, probably not labeled here, is how you all easily tolerate statins. That's again a concern. So these are the concerns with statins and achieving LDL target levels. So going to the first concern, LDL target is only getting stricter with the time. See, Lipid Association of India in 2020 defined major atherosclerotic cardiovascular risk factors. That is, some premature cardiovascular disease like has cardiovascular events occurring in less than 45 years in male and 55 in female, family history of premature disease, cigarette smoking or tobacco use, high BP, low HDL-C levels. These are major risk factors. And other high risk features like diabetes, CKD, at higher stage, familial hypercholesterolemia, extreme of a single risk factor, coronary calcium score more than 300, non-stenotic carotid plaque, lipoprotein A levels higher. So on moderate risk factors like lipoprotein A levels be moderate, pre-diabetes, impaired carotid intima media thickness, calcium score between 100 to 300, and so on and so forth. The list is there. So putting them all together, if 0 to only one major risk factors exist, is low risk. Whereas very high risk is 3 major or 2 major with more than one moderate risk factors exist. It is high risk. Yes, very high risk they define as pre-existing atherosclerotic, that is for secondary prevention, diabetes with more than 2 major, or familial homozygous hypercholesterolemia. So category A are those, that is coronary artery disease with more than one feature of high risk group. Category B is coronary artery disease with more than one feature of very high risk group of, or recurrent acute coronary syndrome patients within 1 year despite LDL levels correction. So they are that is category B, which is marked red because the worst category. So how do we go about what are the targets set by Indian Association for Lipids? So in category B, target is less than 30 for LDL. consider drug therapy, even if it's more than 30. So how easy to achieve this 30? And it's not that this category B, extreme high risk group, are very rare. They've been in fact very quite common in our practice. But how often we achieve LDL levels 30, or how easy it is to achieve LDL levels 30? The bigger question. At least 50 in very high risk group, that's the target. Even that's only probably 30-40% of patients achieve. High risk is less than 70. This probably we tend to achieve reasonably often with statins or other drugs. Moderate risk 100 and low risk 100, that's fine. And not just with the lipid targets from Indian association, even European associations, the targets are getting only stricter with time. In very high risk group in 2016, they gave a target of 70. Whereas in 2019, they wanted to be extra cautious based on the events that's happening with higher LDL levels. So target revised to 55. In high risk group, earlier target was 100. Now it is revised to less than 70, even by the Europeans. Moderate 115 to 100, low risk 115 remained the same. So the targets are only getting stricter. As we know, LDL levels as low as 25 as certainly has got a benefits of cardiovascular event reduction. So based on this European revised guidelines, how many of patients do we have controlled LDL levels? There is a cross-sectional observational study done, that is Da Vinci study, based out of close to 6,000 patients, included both for primary and secondary prevention, close to equal number. And look at the numbers. Only 27% of eligible patients are receiving high intensity statins, though they were supposed to receive. So more than two-thirds are not receiving the high intensity statins for various reasons. And only 30% of patients achieve lipid goals with high intensity statins. That's probably, shame. We create guidelines, we know the fact, but still, we are achieving the facts only in one third or less than one third. And that too in a developed nations like European countries. And in very high risk patients, 37.5% are receiving high intensity statins. 22% only achieved targets in spite of this high intensity statins. So these are very embarrassing figures. So how do we bridge the gap? The gap is huge actually here, but how do we bridge the gap? And probably why were they not prescribed statins? Majority of them would not have been prescribed because, or would have been prescribed, but they would not be tolerating. That could have been a higher possibility. So here comes second question: how to achieve LDL targets after maximum tolerated statins? The tolerating statins itself is a challenge, and in spite of putting maximum dose of statins, additional drugs that's available is ezetimibe with cardiovascular event reduction benefits are ezetimibe and PCSK9 inhibitors. But ezetimibe is affordable, accessible for the mass market, but PCSK9 not quite easily, at least in Indian market. So close to 50% are on high intensity statins, and achievement is in spite of putting them on ezetimibe high intensity statins is 60-70%. Likewise, you need to combine multiple set of drugs. In spite of them, the target achievement in patients could only be 80 to 90%. 5 to 10%, 10 to 20%, but still there's a scope for our science to get better to achieve 100% target. So high intensity statins has low adherence, which leads to higher MACE events. In one of the studies done in 23,000 ACS patients, 66% of them did not take high intensity statins after discharge because tolerating it, adherence to statins are poor. For large reason could be poor tolerability with it, or higher muscle aches or muscle related symptoms, and a few other symptoms associated with the high dose statins. So that brings in intolerability of high dose statins, though efficacy of high dose statins with for LDL reduction or clinical cardiovascular outcome predictions are much better. How far it is practically possible because of poor tolerability? That's a big question, and that's a big gap. So this novel drug, bempedoic acid, plays a huge role probably in bridging the gap, certainly as observed in the trials. And also, it is not a new anymore. It's close to a year, if I'm not wrong. Been practicing it for a while now, and I've been observing a tremendous response from this drug. Efficacy matching, or could be even outpowering statins in terms of LDL reduction. Certainly there. Clinical outcomes in real world we'll get to know with time, but clinical outcomes in tested, that is randomized trials, yes, They recently the results are out, and that's the trial that we're going to discuss in the next slides. That's clear outcome trials. So it is actually an enzyme inhibitor. This enzyme, it is given as 180 mg twice with or without food, and the indications are more or less same as for statins. The journey of this drug, FDA approved in February 2020, then European, then recommended by different societies and so on and so forth. In April, a month ago, it's recommended by LEP as well. Clear Outcomes is a landmark trial of this drug for cardiovascular outcome reductions. Outcome trial results were out on March 23rd, 2023. So we now, I mean, for 2 months old now after clinical outcome reduction, I mean, ever since the clinical outcome trials are done. And how does it act? It acts one step above where the statins act. It's an enzyme inhibitor, and idea is to reduce LDL cholesterol. So it also has adverse effect of elevating uric acid levels. That's the only caution. Probably it exercises. So half-life is 21 hours, and is majority is excreted through kidneys, others through less through feces. Renal impairment, hepatic impairment, no dose adjustments required. And in patients with prior history of gout, exercise with caution. Are patients taking steroids, fluoroquinolones, and those with renal failure, or with a history of tendon rupture, exercise with bit of caution. And those taking simvastatin or pravastatin high dose also avoid concomitant use of this drug. And discontinue if tendon rupture occurs. Consider discontinuing if joint pain, swelling, or joint issues occur. Use it cautiously in patients with a prior gout as well. So this was the trial, late breaking clinical trial published in ACC 2023 Clear Outcomes trial, wherein the primary endpoints are cardiovascular death, non-fatal MI, non-fatal stroke, or coronary vascularization. The 4 component event reduction followed for 2 years and done in 1,620 odd patients. Patients included were statin intolerant patients are also included. The outcomes, I mean, the baseline parameters are matched across both the groups, that is bempedoic acid and placebo group, and majority of them are on statins as well. The 4 component MACE reduction, the RRR observed with 4-point MACE reduction is 13%, 3-point MACE with in 15%, fatal or non-fatal MI 23% are a relative risk reduction, and coronary vascularization reduced in about close to 20%. So we had to see the mortality benefit, but yeah, these are certainly valuable clinical parameters, clinical outcome parameters with reasonable impact in survival and practice and morbidity. So this was again in a other form of description of the same. So not just the event reduction, more importantly, what surprised in is significant LDL reduction, 22% of LDL reduction compared to placebo with the bempedoic acid. That's goes for a very good efficacy, and more importantly, not just LDL reduction, hsCRP. This was plausible attribute. Statin rosuvastatin particular gained in for clinical event reduction in Jupiter trial. Even here, I mean, even this drug reduces hsCRP in an efficient and significant way compared to placebo. So if you look at the safety outcome analysis, there's hardly any difference for all the reasons mentioned. The myalgias are only 5-6%, leading to discontinuation is about 10%, and a few others, which did not differ from the placebo. So there is no upscale significant adverse events or safety cautions noted with this drug. So bempedoic acid became the first ACE inhibitor and first oral non-statin to demonstrate significant reduction of MACE4 events in patients who are at high risk of cardiovascular disease with a documented statin intolerance and elevated LDL cholesterol levels. So bempedoic acid is an effective alternative for statin intolerant patients. It's well tolerated mixed population of both primary and secondary prevention, and the patients who are unable to or unwilling to take statins. And bempedoic acid reduced LDL by 21%, hsCRP by 22%. A slight increase in gout and bile stones, and primary endpoint reduction, 4-point happened in 13% RRR, 3-point reduction happened in 15%, MI 23, and coronary vascularization 19%. And it's an effective approach to reduce major cardiac events in statin intolerant patients. So this is just a beginning in the statin intolerant patients, or even those and tolerating statins but unable to achieve the target outcomes with LDL. Bempedoic acid is certainly doing a huge impact in the practice, as observed in the trials already published, also in the real world observation with personal experience of mine. So with that, I close. Thank you. I will be happy to interact and take views and questions.
Thank you so much, sir, for such a lucid and to the point presentation. Of course, there are few questions on my screen. I would like to ask those few questions. The first question is, sir, you were talking about ESC 2019 guideline, and related to that, how one can go low about LDL cholesterol? How low can be possible, and is it safe? Is there any neurological complications associated with
No,
it?
safety concerns were established, and there are, I mean, randomized control trials, and in fact, actually, the meta-analysis certainly showed among the positive trials pooled together, multiple positive trials pooled together, LDL as low as 25. I mean, the continuous cardiovascular event reduction benefits continue persistently observed till as low as 25, or it could be even lower also. We don't know the data, but at least till 25 certainly we know, but coming not at the cost of safety outcomes. Without compromising safety, benefits are certainly there up till 25 levels. There are, in fact, not clinical studies, but studies done how low could be the LDL level low, LDL zero. Is it a possibility? There are few trials and few studies. I mean, hypothetical studies were also been happening in the interest of killing the LDL so low as zero actually. But so I mean, we should go by the evidence, clinical evidence. The data is clear up till 25. Certainly, the clinical outcomes are better up till as low as 25. Certainly, with secondary prevention.
Thank you so much, sir. There's next question about my patient is having dyslipidemia. It's congenital dyslipidemia, and if I increase the dose of statin, patient start complaining about muscle-related symptoms. So, shall I directly jump onto bempedoic or add ezetimibe to this patient?
This familial hypercholesterolemia, especially with homozygous, very difficult to handle them, very difficult to achieve their LDL levels down. Forget about 25 or 50 or 70, even getting close to 100 is also a very challenging task. As long as they don't have any events, but I mean, we reasonably can afford to breathe, because it's in the interest of primary prevention, at least diagnose known bit early before an event happened. I mean, somebody who thrown already an event and we have to be even more aggressive, very challenging. Answer is not sorted yet. But among the existing options, what can we do? Yeah, certainly go with high dose statins. And the bigger problem is when somebody is not tolerating the statins. That's again a bigger problem. Maybe switching from hydrophilic to lipophilic, or lipophilic to hydrophilic, whichever one is using. Say if somebody is using atorvastatin, I have a bit of switching to rosuvastatin. If somebody is using rosuvastatin, not tolerating, maybe I try atorvastatin 80. So even then, if you're not achieving, or even that somebody is not tolerating, I kind of balance by reducing the dose of statins, not completely disposing it off, or maybe give them a statin free time for a week and then restart it at low dose, gradually escalate, or reducing the dose of statin, but again certainly borrow the benefits of ezetimibe and bempedoic acid as well. We also know, I mean, we have PCSK9, an aggressive molecule with a very potent, I mean, with efficacy certainly there in reducing LDL, but how far it's practically available for the mass market, I don't know. I hardly have an experience, because it's quite an expensive affair with the PCSK9, not a very easily available. Only one company, I believe, is doing it. So that's practically out of practical market. So, but existing easily available drugs, which pitches in is ezetimibe and bempedoic acid. Again, ezetimibe is not very efficacious compared to bempedoic acid. It's not like you can replace ezetimibe to bempedoic acid. They only add-ons actually to statin. Statin still is number one, but I would actually prefer bempedoic acid to other drugs, and get certainly bempedoic acid by whatever means, to kill the LDL levels as low as possible if statins are, I mean, somebody is not tolerating high dose of statins. Good thing with bempedoic acid is I hardly observed any issues, though I read joint pains or joint aches, I mean, hyperuricemia related issues. Maybe numbers may not be good enough for me to comment certainly, but yeah, I hardly have any issues, significant issues good enough to asking to stop the drug happening so far in my practice.
Thanks, sir. That's wonderful. This next question is statin-induced myopathy. Is it seen in this drug? That's one question. And the same doctor is asking about every elderly above 75 years. Is it safe?
Oh, our elderly, I don't know. I'm not sure. Maybe I'll leave the question for you guys. Maybe I should revise the trial baseline data because the mean age was not that high actually. So I'm not sure about that question part. But what was the initial part of the question? Sorry. Statin related myopathy, correct. The statin related associated myopathy, though in the studies they say it is like 3 to 5% or significant to the extent of increasing the enzymes like muscle enzymes beyond 1,000, say CPK beyond 1,000 levels are like less than 3% or 1%. But in practice, I don't know, but in different or not relevant to CPK levels, but in practice, I often see this myalgia complaints with statins certainly improving with reducing the dose or stopping the statins. That's a very common observation to me actually. I'm a pro statin guy actually, but I mean I'm very reluctant to get the statin dose down or statin dose. I try my best to convince the patient, but I end up in failing most of the times because it's so powerful in giving these symptoms good enough, I mean high potent enough to make them stop the drug. So that's where I'm a bit scared actually. So fortunately in this bempedoic acid, with whatever experience, maybe I would be having 100 patients of mine on bempedoic acid. These are rough numbers. Fortunately, yeah, I have never heard of this myalgia related symptoms. There is also science behind that. This statin gets activated, or statin enzyme activation happens in skeletal muscle, whereas with bempedoic acid there is no connection or no activity in skeletal muscles. That could also be one reason. But even otherwise, in the real world, I don't see any similar issues like myalgias, muscle aches that we often see with the high dose statins. I mean, I'm not experiencing with bempedoic acid. If any others have any view to differ, I'll be happy to receive.
Yes, sir. Thank you so much. There's one question about 75 years old, and you were one slide you showed that one is to monitor the patients with 60 years of age taking corticosteroids or fluoroquinolones
Fluoroquinolones,
with
yeah.
renal failure or history of tendon rupture, whereas we have to warn of potential of tendon rupture or advise
They
patients.
only ask
It's
for caution.
observed. Yeah, it was a caution, and it was observed in very less number of patients.
Fair enough.
Yes. Sir, next question is about my patient is diabetes patient, hypertensive patient. There's no much information which is being provided, but uh, how much LDL cholesterol should I target for this patient?
It depends on which category of patient is. If he already suffered an event, he lands into secondary prevention category. If he hasn't suffered an event, good. But still, he is diabetic, not concerned much about hypertension, though Lipid Association gave importance to hypertension as well. But otherwise, across the societies with evidence backing, solid evidence backing, diabetes has a powerful impact in going along with this dyslipidemia profile and metabolic syndrome. So because your patient is diabetic, my patients, I would personally prefer to keep, even for primary prevention, at least less than 70, LDL levels less than 70. So that holds good for, as per the ACC, American Society recommendations as well. They don't suggest the number. The recommendation is to get the number down by at least 50% from the baseline. That's the recommendation from American Society. But as a number, because that keeps the things easy and acceptable and easy to absorb to the patients as well, I give them a target of 70 to prevent event reduction. But if diabetic patients already through ACS event, coronary acute events, then I prefer to keep their LDL levels at the best possible to keep it under 50. various, the LAI discussion we already saw in few slides. Extremely high risk group, recurrent events happening in spite of LDL correction. There they recommend LDL levels less than 30. I mean, they are very less. I mean, say less percentage of patients, I believe. Most of the times their LDL would not have been actually followed, or it is only on the index day, incident day, that we would observe LDL less than 50. Usually, if LDL levels are less than 50 and diabetes is controlled, the event rates are very less.
That's nice, sir. Next question is about uh, this is from my side. What do you weigh more, LDL cholesterol or triglycerides? Nowadays, LDL cholesterol is being targeted most often. Some articles saying that triglycerides is not much that much dangerous, but LDL cholesterol is. So, what do you weigh more?
This is
And
more a question actually. For in the question comes from the general public, because now that preventive health check packages and preventive health approach check approaches are quite normal. People tend to observe that triglyceride levels quite high in majority of the patients. We being Indians being part of South Asia insulin resistance is quite high. South Asians triglyceride levels and baseline levels are quite high. So that's case majority of patients actually. We often see levels more than 250, but triglyceride is a concern usually when it is more than 800. Again, concern more in the direction of pancreas. Actually, it can cause pancreatitis, acute pancreatitis, and stuff. Not that triglyceride elevation doesn't have an impact on the vasculature. Certainly, triglyceride also has an impact on the vasculature. Now the concept boils down to calculating ApoB values rather than looking at LDL or triglyceride levels, because it is ApoB which is harmful. LDL carries more ApoB, that's why weightage is more towards LDL. So if every laboratory cannot assess ApoB, and it is expensive as well. So in that case, we have to boil down to practical approach. Practical approach, LDL weighs way above from cardiovascular perspective. LDL impact carries way above compared to triglycerides. That's why nowhere in the recommendations from the societies, triglyceride takes a major share. Not that it is not given a share, it is given as an additional contributing marker to risk stratification. But the primary target is along LDL. So LDL is LDL, the impact of LDL or impact of elevated LDL or impact in reducing LDL in cardiovascular disease and cardiovascular practice is certainly weighs much above than the triglycerides.
Since you were talking about apolipoprotein A and apolipoprotein B, you talked about apolipoprotein B. So some of my interactions with the doctor saying that if apolipoprotein A is also greater than 30, they consider that patient is having, patient is also with comorbid conditions. So they try and consider as option of additional LDL cholesterol reduction option. So what is your take on that? Apolipoprotein A,
Not
apolipoprotein
about
B.
apoprotein A, if I'm not wrong. This is about lipoprotein A, which has a risk influencing ability. It is
Yes.
ApoB. It is ApoB, which is a lipoprotein molecule that runs in the LDL and triglyceride, which has a gravity or a tendency to get attracted to the vascular walls and throw a plaque actually. So it is ApoB, and ApoB and LDL usually they go together. And ApoB is not easily weighable in the conventional labs or regular labs. So that's where we borrow with the help of LDL, which is easily available. Certainly, lipoprotein A elevation is not an acquired thing. It is a genetic thing. It's a marker, but it's a risk influencing marker. Lipoprotein levels more than apoprotein A levels more than 50, they are at higher cardiovascular risk. 1/4 of Indians, of course, have elevated lipoprotein A levels.
Thank you, sir. This was a wonderful presentation, and the interaction, the questions which were asked by audience were quite interesting. Without
Enjoyed the meet.
yes. Sir, would like to ask your final comments before we conclude this session. So, closing remarks from your side.
I mean, I have to say, since we're speaking of Bemdac, it's not an easy thing that we can, as I just started, it's not something to be brushed off. I also see probably, to balance our inertia, I mean, clinicians' inertia, I would seek put a request or kind of whatever you can call, on the industry actually to give importance to the market in, importance to the drug in the market and promote it in an aggressive way, take it down to the physicians and every possible physician who is handling, the general public, because the benefits are humongous and the cost is very affordable. So this benefit coming at this price, I mean, which has a significantly, the survival advantage, probably, that is not known, but yeah, certainly it has a survival advantage hidden behind in the community. The benefit has to be passed on to the public. So I would request the viewers, participants, and I would request more, I mean, to the industry. This is just in the beginning stage, I understand. I would request industry to actually make more attempts, because the many drugs I've seen, and industry making a huge attempts actually. I mean, finally the product failing, or with for a less benefit products, like say one example, Azilsartan, I believe, an antihypertensive. Too many companies pitched in, too many CMA is happening, too many stuff happened for a marginal benefit, and eventually the drug failed, hardly happening. But similar approach I expected from this drug, I believe, to my knowledge, it's not happening. Maybe it's high time, probably industry should give its due importance to this drug in promoting and taking it out to physicians in a big way actually. Whether the general public,
Certainly,
especially developing countries like India, should
yeah.
benefit out of it.
Yeah, certainly, sir. This was indeed a very nice suggestion, and of course, this is Clear Talk is of course intended towards spreading the awareness about bempedoic acid to the HCPs, and of course, we indeed it was a pleasure having you talking about clear outcomes trial and benefits of bempedoic acid. So your in-clinic expertise and experience will definitely help all the delegates today who are attending this Clear Talk in such a great manner. And so it was wonderful, sir, having you on this session. Thanking you once again from Zydus Life Sciences, thanking all the delegates for your active participation. And thank you so much, sir. Thank you so much for being with us.
Thank you, Zadesh. Thank you, Satish. Thank you, all the participants.